Thank you everyone for joining us. And I see that we are right on track with the first live case from Dr. Suresh Kumar and Dr.C.Sunder from Kauvery Hospital in Chennai. Welcome to you. Can you hear us?
Yes.
Yeah.
Good afternoon, everyone. Respected chairpersons and panelists, greetings from Chennai Kauvery Hospital. I'm Dr. KP Suresh Kumar. Along with me, I have my friend and colleague, Dr.C.Sunder, and we have got the whole dedicated cath lab team with us. Thank you, the organizers of TCT, Srinivasa Kumar and others, for giving us an opportunity. Now, let us start the proceedings. I will present the case. Can you please show the case? Yes. This is the story of a 51-year-old gentleman. He has exceptional angina for the past 1 year, and he was on optimum medical treatment, worsening of symptoms for the past 1 month. He's a chronic smoker and is detected to have diabetes mellitus 6 months ago. His ECG was normal and echo normal LV function, no previous myocardial infarctions, and TMT was stage 1 positive, strongly positive for inducible ischemia. LV renal functions were normal. Can you show the case, please? Angiogram. So we are taking him for coronary angiogram. It's coming?
Yeah.
Okay. Right. The coronary angiogram, the left coronary injection shows that the left main is normal. LAD, the proximal LAD is calcific, and mid LAD, next one, the mid LAD has got a 90% calcific stenosis till the S2, and after that, the distal LAD has got a discrete 90% calcific lesion. I think LAD lesions has multiple calcification. Diagonal has got a diffuse 90% stenosis. Previous view. The circumflex, the proximal and distal circumflex are normal. OM1 is diffusely diseased, and OM2 has got some minor lesions in the mid segment. So actually, he was advised bypass surgery from some other centers. He refused because of the age and so he wanted he opted for PTCA. So we are taking him for PTCA to LAD. Now we are used a 6 of EBU 3.3. You can show that. And BMW wire. We dilated both the lesions with. You can go ahead. Okay, and with 2 into 15 mm balloon on both sides. Then we thought of doing an OCT. Now I will stop here for the panelists and judges and the chairpersons for their interaction. We have done a balloon dilatation 2 into 15 mm, the distal LAD as well as proximal LAD. The distal LAD opened up with some minor dissection. Proximal LAD has also opened up. So we did an OCT. Shall I go ahead with OCT?
Well, let me ask our panel on what their thoughts are. Thank you for that great presentation of that case and stressing the fact that he was on optimal medical therapy and refused CABG, which would have been a reasonable option to consider, although the distal LAD didn't seem like a great target. So maybe we'll start off from what are your thoughts so far?
Yeah, and this LAD looks like a very diffusely diseased from distal to the proximal. He has done an balloon dilatation. Probably I will go with imaging and see this. What is the size of the vessel distally and to what happened after the balloon angioplasty. I will go with an imaging.
Perfect. What do you think of OCT versus IVUS hair, and what strategy do you think?
Well, I'm terribly biased. I'm a totally OCT person. So I would definitely choose OCT in this because one, I can get how much of calcium, what is the extent and what is the size of the calcium and the presence of nodules. If so, what is this thing? He says he may have dissected the distal lesion. That will also be seen far better in an OCT. IVUS, if you are comfortable with it, probably you can get the same information from an IVUS also. But personally, I would try OCT as my first choice of imaging in this case.
Perfect. And we see that they likely have an OCT run for us. What do you think?
Yeah, that's because it's diffusely diseased. I can say the multiple level lesions and the calcific lesions, probably plaque modification already done, and OCT definitely gives a good information as a pre PCI.
So we'll move on to the rest of the panel as we go later in the case, but it seems the consensus is that we're ready to see the OCT.
Thank you, sir. And we
have
have
one
acquired a
question
new
to
OCT
ask,
machine there with
Suresh.
the Ultron
One
one.
is that once your catheter becomes occlusive, the distal runoff of the contrast is going to be a little sluggish. The small
Yeah.
caliber vessels, the
Yes.
flow is not going to be good. I'm a little
Yeah.
skeptical about the images you're going to get.
No. We have cannulated
Once you dilate it
while,
to
while
2
taking
millimeter, I
the
think,
OCT runs, we have
it should be,
cannulated it fully.
uh,
Your OCT run,
visible,
please.
and the contrast should go around it.
Okay, so let's see your next steps.
Yeah, sure.
Occlusive.
Dr. Suresh, we are ready to see the OCT.
Yeah.
Yeah, please. Your OCT machine.
Can't hear you though.
Hello.
Hello, you can hear us, no?
We can't hear you, so.
Okay.
Oh,
Right.
there we go.
Please show the OCT machine, OCT charger. Okay.
You can tell.
We're ready
Okay.
to see the OCT.
Yeah, we dilated both the proximal and distal, then with the 2 mm balloon, but then the OCT catheter was not going in. So we have dilated with 2.5 mm balloon again. Then
Dr.
those
Suresh, your
catheter was
voice
going in.
broke up a little.
Okay.
Can we turn up his mic so we can hear what he's saying?
You can.
Okay, better. Go ahead, sir.
Can you hear me?
Yeah.
Ready?
We are audible. Hello.
Your voice is gone again.
Yeah.
The audio signal is not clear to us.
You talk.
Yeah.
You
Hello? Yeah. Can you hear me?
Very faintly. Yeah, initially it was good.
Hello? Oh, no. Now?
Okay, maybe while
No,
we're getting
yeah.
the audio back, we could just see the
I'll try to speak loudly. We have dilated the distal and proximal with a 2 mm balloon. After that, we tried to pass the OCT catheter. It was not going. So we dilated again with a 2.5 mm balloon proximally. At that time, the OCT catheter went in. We'll show you the OCT images. Yeah, you can talk to doctor.
Perfect. Thank you.
You are able to see the OCT now?
We're able to see the OCT and we can
Yeah.
hear you, but not great.
Yeah.
Can you see the full screen?
Yeah. Put it in full screen. The OCT.
So the angio registration will miss.
Yeah. Just put it in a full
That is
screen.
a new OCT with Ultron 1 software. In the longitudinal section, it shows that it's all color coded. That yellow is the calcium. Where is it? You can show it here. No, you can do that.
And if you can put the OCT up there, that would be
Yeah, okay.
fantastic. So as we suspected on the panel that the 2O balloon might not allow the OCT catheter, so the correct choice is of course to
Absolutely.
balloon it a little more and
Yeah.
then
That yellow is the calcium, and the yellow color is the calcium, and the dots which is inside the lumen is the side branches, and the dots in the periphery are the media. So no, you can go ahead with the OCT explanation.
there we go. If you can, perfect.
Yeah. From
Prox.
it's a
Yep.
little different. You can see from the left side to right side, it is a proximal to distal run in this newer Ultron software.
Suresh,
And-
can you make it full screen, please?
Yeah.
Full screen. Can you make it full screen?
please.
Full OCT. And the angio எடுத்துட்டு you can. I think it's
Yeah.
Is it okay?
That's all.
Yeah, this will do.
It's
If you
fine.
can make the OCT full screen if possible, but otherwise we should move on.
I think it's
As
a
in
bit
move on.
difficult for us here.
Hey, move on,
Okay.
please continue.
Yeah, you can start.
Yeah,
running.
let's go ahead.
The plaque with calcium, it's from the left main ostium, and then if you can see the run here, and it's a proximal LED, and now you can see some fibrofatty plaque here, and there is a first is septal opening, and then it comes here, and we are able to see the diagonal ostium here, and you can see the calcium arc, which is more than 103-degree angle, and the thickness of the calcium is more than 1 millimeter. And then here you can see the lakes of calcium here and there, and it is very thick calcium, and the angle it's more than 185, and you can go further. It is crossing more than 200-degree. And it's a thick calcium. It is occupying in the mid LED after the diagonal. And this is the full run, and can see some of the cracks here and there, and dissection also created by the balloon dilatation. And it is more of a distal. Here it comes the distal LED, and can see the lumen is occluded with the huge blocks. Yeah, it is the septal, it's opening here, and it's the distal LED you can run, and then you can see the distal LED also has a huge block and with some balloon dissections here.
So
The vessel size here in the distal LED is very, very small, and I can see the EL area of only 2 millimeter EL to EL. And the lumen area is 1.6. And may I know the comments from the dice?
Well, let me ask our
Yeah,
panel
Dr.
now,
Suresh,
after the OCT, what you
What
think?
do you think, what is more important, the angle or length or the width of the calcium for non-crossing of the balloon? Which is more important, the angle or thickness or length of the calcium?
I think all the three are important. Is the thickness of the calcium and the angle of the calcium and the length of calcium. Here the most of the places the angle of the calcium is more than 180. So definitely one is significant, and the thickness of the calcium is more than around 0.7 millimeter, 0.8 millimeter. So both these satisfy the, and the length is definitely long. So all the three satisfy the criteria for a calcium modification technique. Now the question is, what calcium modification technique you use? Use a rota, IVL, or cutting balloon? Your panelists or the chairperson, your comments and opinions, please.
Yeah, let me ask our panel on the other side. So
So the lesion looks to be very long. What are you planning? If you plan an IVL, probably one balloon will not be sufficient to break the calcium all around. So I don't think one IVL balloon is going to work for you. So if you have a choice, rota also, like the vessel size is not too great distally.
Yeah.
So probably the proximal part you could rota. But if you try to go too much down, you might land up in trouble. So it's a difficult decision to make. Another thing, there's a large diagonal branch there,
Yeah.
which we see two branches actually. There's a diagonal with a superior and an inferior branch. Doesn't look like an insignificant branch to me. So I think your plan would be to stand above that branch. So what are you planning for, that branch? Because we don't want
We
to
are
close.
planning to do a DCB to the diagonal after dilatation.
Yes. So yeah, because that didn't come up in the in our discussion. So I just thought I would point that one out also.
So I think the concern, of course, here is the extent of the calcium, the thickness of the calcium, the side branch that needs to be protected, whether one IVL balloon would be sufficient, whether it would cross distally, and whether the distal vessel is suitable for rotational atherectomy, right? I mean, those are the issues to consider.
So one comment
What
from
is the size of the
audience.
proximal LED? What is the size of the proximal LED?
The EL comes around 3.25 here in proximal EL. You can see the proximal. I can show it here.
So if all the three criteria are fulfilled, you have to go for atherectomy, not IVL. Because if you have a length of the calcium and these 3 points are confirmed, then you have to either go for an orbital atherectomy or a rotational atherectomy. That's the point.
And it is also more cost effective as well, right? If you're thinking, as you mentioned on the panel, that one IVL is not enough, that actually definitely is going to increase the cost.
Okay.
Why not just
Okay.
a cutting balloon and followed by non-compliant balloon?
Exactly. That is the exact thing which we have done. Because when we are dilated with a 2.5 mm, there are multiple dissections in the proximal and the distal. So we use a cutting balloon in the proximal, use a 2 into 15 or 2.5 into 15, 10 mm cutting balloon in the proximal part. Yes, next one. Then after that we dilated, no? Yes. It has opened up and the OCT shows multiple. You can see the OCT picture here. It shows multiple deep cuts. You can reverse.
Can you play that?
Yeah, we'll play in that main screen.
Main screen.
Just
Can
run it.
you play the OCT run after the cutting balloon?
Yeah.
Just run
Yes.
it
Run it. OCT run.
from proximal to distal.
There are multiple dissections and deep cuts. Where is that cut deep? Ah, there is one. Okay. Next one here on the lower part also. On the,
Yeah, heavy calcium burden, not quite circumferential, but near circumferential, deep thickness. Okay, any other?
Okay.
So now what is your plan?
Now we have two plans. We'll do a post dilatation again with a 2.75 mm balloon because deep cuts have been made. Now there is no point in using an IVL. So we will dilate once again with the 2.75 because we have gone only up to 2.5 mm balloon. So use a 2.75 mm balloon to dilate it nicely and then try to stent it. Meanwhile, the distal lesions we use a DCB, and you can just show that. And the day just stacked up the dissection, it has come out fairly well. So we don't want to do anything for the distal lesion. Yeah.
So proximally will be using a non-compliant balloon or you will go for a high pressure balloon?
Proximally 2.75. It's a non-compliant balloon I will use. I will use a non-compliant balloon. Next. We use a DCB distally and then next one more. This is the next one. Okay. Right. So what we will do is we'll go with a 2.75 balloon, non-compliant balloon to dilate the proximal LAD, followed by do the stenting. Is it acceptable to all the panelists?
Yeah, that seemed like a good strategy to me. I don't know. Let's ask our other side of the panel on if they have any thoughts on the sizing and that strategy.
Yeah, that seems to be the optimum, and probably that should work.
Okay. Right.
Okay.
We'll give a 2.75 balloon. We'll dilate it and then go ahead.
Perfect.
The DCB has not given an optimal result, even a suboptimal result, I feel. I mean, there's a lot of glare we have here, not able to see the screen.
Okay.
But the result is definitely suboptimal in the distal vessel.
Distal part.
Are you concerned about the runoff in the distal LAD?
Exactly.
So
once you put a stent proximally,
we'll see that. Distal. Okay. Right.
Once you put a
2.7 balloon.
That is the beauty of the DCB, if I may say. DCB never gives an optimal result and doesn't look like 100% expansion.
No.
It gives you the 50 to 70% expansion.
It's very suboptimal.
Definitely it has factor because we have produced a dissection there, no? So when the intimal dissection means definitely we have done a good expansion. Then I think this is enough. We don't want to go there and then expand when dilate once again.
Yeah, and we can see after the proximal intervention on what the distal
2.7 into 15.
May I comment about the distal LAD? Because there is a significant fibrosis.
Yeah.
I think if you use the scoring based upon the ISAR-4 study, if you prepare before delivering the DEB, always do the cutting or
balloon.
scoring.
Yes.
What happens to create controlled dissections? When you put the DEB, the drug will percolate into the tissue. The restiveness is much lower. They compared NC plus DEB versus scoring plus DEB. Almost 45% reduction in the MACE rate compared to NC with it. So that is we always use the scoring. And that is angioscope they use. Scoring only they use.
Perfect. Most of the time when we use the DCB, we use cutting balloon as per the ISR DESIRE trial, which has shown that improving the pre-dilatation will improve the long-term outcome. Okay.
One of the major issues actually after using cutting balloon and a drug-eluting balloon, will you actually identify what type of dissection you created in those vessels without doing an OCT? Even if you do an OCT with a larger injection, your distal vessels are very bad, where you're actually keeping a wire there. Your OCT catheter cannot take as distal as possible. So you just leave it like that.
So that is the study I was trying to quote. 94% of the type A to C dissections were left alone. 94% of them did not create any problems.
Type A to C dissection, how did you identify? That's what
OCT.
OCT you cannot do. I'm telling this wire, if you take as distal as possible, you cannot take the OCT catheter down. That's what I must.
Yeah, so I think vessel size and the fact that it's so distal, the level of diffuse disease, they all impact that. So maybe what we'll do is while you're working up there, let's see if the next site is here, and then then Dr. Suresh, we will come back and see how you guys did.
Right. Thank you. Right.
So we'll circle back with you here in a few minutes. Let's go back to Kauvery Hospital in Chennai, where we have that case.
Hi. Hello.
Hi, welcome back. Dr. Suresh Kumar.
Yeah.
So how are things going?
Yes, yes, we are doing very well. We have dilated the lesion with 2.75 into 15 mm NC balloon. You can show that.
Yeah.
Previous proximal. Yeah, we'll come back a little bit more proximal also. Yeah. Dilated with 2.75 into 15 NC balloon up to 15 ATM. Then next angiogram. Next angiogram. Angio. Yeah. It has opened up in a better way, and we have done an OCT. Show the OCT. Yeah. OCT again.
Is it possible to put the
Yeah.
OCT on a bigger screen?
OCT main screen.
Yeah. And we'll see what the panel thinks after those calcium treating techniques on. But angiographically, it looks we've made a lot of progress.
Yes. We again more lumen, but there is a lot of deep dissections, and
there are some cracks in the calciums, and they can see the dissections, cracks. Just run it. Ratan. Yeah.
Okay.
These are the OCT runs.
So I think you've achieved what you set out to achieve, and I think it's good result.
Yeah.
I just
so
be
we have done
careful.
the stenting in the proximal LAD.
Yeah,
The
obviously.
proximal LAD stenting.
Just make sure at this stage you don't lose the wire.
Yeah, we
Three
have
into-
exchanged
Very
the
Yeah,
wire
we
also.
extend the wire. We put a better wire.
Better wire.
Do
Yeah.
it.
This is 2.75 into 23 Zines, and we have placed it in the proximal to mid LAD, and then it was dilated up to it. We went up to the nominal, and can see the dissection in the distal LAD also. So it was huge dissection. So we wanted to fix it. So we did 2.25 into 18 millimeter stent in that distal LAD. And this was, we went not up to nominal
pressure.
up to 10 millimeter we just went, and then we came out, and this is the final result.
That looks really nice. And the runoff in the distal LAD has improved. That was, I think, the concern of the panel and your concern initially on whether there's a dissection there and whether you're going to have to stent it. So that looks really nice. Any other comments from our, let me ask our panel.
What about the diagonal? Are you planning to leave it alone, or are you planning to go and interfere?
I thought I will leave it alone.
Yeah, for now.
So we wanted to post dilate here,
and we will follow him up later and see how he is.
And we'll take a OCT run at the finish, and then we'll show you.
Yeah, so far the result is good.
Yeah.
Okay. We will dilate the proximal part of the stent with a 3 mm NC balloon.
Yeah.
Okay.
And I think the diagonal still has good flow. So,
Flow. Yeah. Inflow.
so I don't think that we need to go in there and do much.
Yeah.
No minute.
Just to stimulate you, the studies show that if you go into the diagonal and do a drug-eluting balloon, 94% chances that you'll have a perfectly flowing diagonal in the future.
Yeah.
The choice is yours.
Yeah. Okay.
Yeah.
Okay. Thank you.
Picture.
That's what I will try to do that. Okay. Okay. Open. Okay. Enough, no?
Yeah.
Proximal.
Proximal enough.
12. Okay.
It is a 3 into 15 millimeter NC balloon.
NC balloon. Deflate. Okay.
And the lesion looks well expanded on this stent boost.
Yeah.
Right. Okay. Right. Diagonal flow is Dimitri. Diagonal is flowing nicely, so I don't want to do an.
Yeah. No, I think that looks like a really good result compared to where we started.
Starting picture.
Yeah, Dr. Suresh,
Yeah, please.
just a small question.
Yeah.
How much is the gap left between those two stents? The one deployed distally and the one, distal edge of the proximal stent and because not very clear in a small screen here, because so much of hardware has gone through that area which was also probably not a normal area.
Okay, yeah.
So multiple times we have crossed OCT catheters and, things like that there. Definitely there would be a lot of, disturbance of that area. So, and now there is always a risk of the distal edge, restenosis and the proximal edge of the distal stent. So, could there have been strategy to, just kindly stent the whole thing rather than leaving that 8 or 10 millimeter in between?
Because initially
we have disturbed that area a lot.
I think it's more than 20
It's
millimeters.
just a thought.
It's more than
Yeah,
20 millimeters.
definitely, definitely more than 20 millimeter, definitely more than between these two
So
stents.
probably you do an OCT.
Yeah.
Now and we can see how that area looks like.
Yeah.
We'll see the
Right.
OCT.
Okay.
Perfect. Well, I think that's a great result. We're gonna go back. Dr. Suresh, thank you so much for
Thank you.
showing that. That looks fantastic.
Thank you. Thank you all the chairpersons and panelists, and thank you. the
Very,
TCT
very,
organizers.
very well
Thanks a lot.
done. And this patient will feel a lot better. So let's go to Chennai where we had that complex calcific lesion and see what their final result was with Dr. Suresh.
Yeah. Thank you. Thank you very much for coming back to us. Now, this is the final picture. The proximal LAD stent and the distal LAD stent. In between, there is a myocardial bridge, which we are seeing. The proximal stent port was done with 3 into 15 mm NC balloon at 20 ATM. I will show you the OCT run at the end. Somebody has asked what is the distance between these two stents. It's about 20 millimeter. It came to around 18 to 20 millimeter.
Now, angiographically, it looks really good. So we're excited to see the final OCT picture.
Dr. Suresh, one question from the audience actually.
Yeah, please,
you did a dub.
Yeah.
Dissected, so you put a dust there.
Yeah.
Is there any concern regarding the concentration of
No.
drug there?
No, see, we need large scale studies, but there are small case reports where people have done a drug-coated balloon, and after that dissection, then the flow was not good, and they put a DES, and then follow up. There is no problem. There's no vessel injury. There is no adverse effects reported. But we need large scale studies on that.
Dr. Suresh, was that bridge visible when we started the procedure, or
I
it's
didn't
the newly
appreciate
formed
it.
bridge?
Where was?
Actually, in the angiogram, we were not able to see such
We
a
were also
clear
not able to
bridging.
see.
There is.
But
No,
now it looks
Stent
really,
90.
really nice. And the myocardial bridge between the two segments is very visible.
Yeah.
Yeah.
In the angiogram, initial angiogram, it was not
proximal MSA.
visible, but now after putting the stent, it was visible clearly.
So good, we didn't put a full metal jacket.
Yeah.
Exactly. And the proximal MSA is around 4.8 or 5, 5.1, 5.4. Proximal part of the stent. And the stent expansion came to around 90%. You can see that.
Yeah, this is a fantastic result. Congratulations. What a great job.
Thank you very much. Thank you very much.